Welcome everyone to Healthy Aging, Maintaining Your Health and Wellness, a collaborative benefactor event where the College of Health has teamed up with the University of Utah Alumni Association to bring you a remarkable lineup of speakers to present on their research virtually and to all alumni of the U of U. I'm Dave Perrin, the College of Health's Dean. College of Health is one of 5 academic units in U of U Health, along with the School of Medicine, School of Dentistry, College of Pharmacy, and College of Nursing. The College of Health is leading a complex shift in healthcare by advancing the industry's ability to prevent chronic illness, restore health, and maintain wellness. We are doing so by developing and implementing innovative science and educating the next generation of practitioners and researchers. We are especially interested in improving the health and wellness of all individuals across the lifespan. Before we begin with our first presentation, I would like to introduce you to our speakers, 4 outstanding faculty members in the College of Health. Our first speaker will be Micah Drummond. Dr. Drummond is Associate Professor in the Department of Physical Therapy and Athletic Training and is a University Presidential Scholar, a prestigious designation that recognizes early to mid-career faculty members' accomplishments in research and education. His lab focuses on 2 general research themes. 1, understanding the cellular and molecular mechanisms of muscle growth and metabolic function in healthy and mobility impaired older adults, and 2, novel exercise and nutritional strategies to improve muscle, metabolic, and physical function deficits in older adults' recovery during rehabilitation. Our second speaker will be Rhonda Nelson. Dr. Nelson is Assistant Professor in the Department of Occupational and Recreational Therapies. Her research focuses on technology-based recreation interventions that can be used for therapeutic purposes in rehabilitation and health promotion. In 2018, she received a Scholarly Achievement Award from the American Therapeutic Recreation Association and was elected a Fellow of the National Academy of Recreational Therapists. Skylar Jennings. Dr. Jennings is Associate Professor in the Department of Communication Sciences and Disorders. He studies how the healthy auditory system adapts to sound, such as when a person enters a noisy environment. His long-term research goal is to understand how adaptation enhances perception in noise-hearing listeners and how altered adaptation results in degraded perception in noise and hearing-impaired listeners. You may have seen Dr. Jennings' image around campus as a College of Health banner campaign scholar. Our final speaker will be Alex Terrell. Dr. Terrell is Assistant Professor in the Department of Occupational and Recreational Therapies. With a background in clinical psychology, her research encompasses 3 areas. 1, adjustment to chronic conditions such as stroke and associated disability. 2, the role of close relationships in managing chronic conditions, to include caregiving. And 3, positive psychology. In 2018, Dr. Terrell represented the College of Health in Vitae, U of U Health's showcasing of early career investigators for their pioneering research programs. So, without further ado, we'll turn to Dr. Micah Drummond.
All right, well, good evening, everyone. I'm not sure how many of you are out there, but I'm excited to do this presentation. This is a great opportunity to share some of my work with you and what I'm doing to maintain healthy muscle as we age. As Dean Perrin said, my name is Micah Drummond. I'm out of the Department of Physical Therapy and Athletic Training. I spent a great deal of time with significant interest and passion in the field of muscle aging and rehabilitation. So hopefully some of the stuff I share with you may be new and informative to you. Next. So the popular understanding of muscle has generally been accepted as a bunch of tissue that can be shaped and molded to make one look good. Or in the case of athletics, muscle could be useful to excel in a particular sport or event. Next. Not only is muscle responsible for the obvious, for you to get from point A to point B, but but muscle is the main tissue that helps you regulate your blood sugar following a meal. And muscle is the largest storage of glycogen, which is related to energy or endurance, and is the primary site for energy expenditure, both at rest and during exercise. Next. Muscle also communicates with many other tissues in the body in the form of myokines. These are important to maintain your health and function. Next slide. Another important function of muscle is physical resilience, as you can see on the left. Resilience is the ability to resist or recover following a stressor like surgery, illness, or injury. In fact, those with low resilience, those with low muscle mass or lower resilience have a harder time recovering from traumatic physical events and often have higher rates of complication following surgery and infection. It is thought that the inability to have inadequate muscle resilience could accelerate age-related loss of skeletal muscle mass and function, which has been termed sarcopenia, which you can see there on the slide, which is also known as poverty of the flesh. Sarcopenia is the most important cause of frailty in older persons and is a major factor involved in poor outcomes in people with diabetes. Next slide. With aging, we can all appreciate that there are many changes to our body, such as increase in body weight and body fat. In regards to muscle mass, we lose about 3 to 5% of muscle mass after the age of 30, such that by the time you're 65 years old, you've probably lost maybe a quarter of your muscle compared to your youth. It is possible that poor muscle resilience to stressors may contribute and further accelerate this loss in muscle and strength with time. Next slide. One of the stressors contributing to age-related loss of muscle and strength are periods of muscle disuse. Next. Life could be filled with undesirable events that are characterized by periods of disuse, like following illness, injury, or surgery. Next. These events are characterized by rapid muscle loss and deconditioning, followed by a slow and possibly inadequate muscle recovery, as denoted by the gray shading and the red dotted line on the right. This is a problem because many older adults have very limited muscle reserve, such that any further loss of muscle following these traumatic events will slowly affect physical function. Next slide. Here's an example of a thigh cross-sectional area of someone before and after knee replacement. And this is also showing information 2 weeks after surgery. So 2 weeks after surgery, if you could see in the second column of muscle slices there, that's 2 weeks after surgery, that the individual on the top is the total knee replacement leg, and the other is the other limb. Well, this individual lost around 12% of their muscle in the leg that had surgery, but also in the non-surgery leg, likely due to just not moving around very much or a period of disuse, they also lost 6% of muscle mass in the leg that didn't even have surgery. And so this is a particular problem even after these traumatic events, where individuals may not move around very much, indicating that this period of disuse may not just be a couple of days or a couple of weeks, it could be a couple of months, further resulting in muscle deterioration. Next slide. Unexpected events of muscle disuse and recovery are quite reminiscent of my grandfather's life. So my grandfather remained healthy and disease-free for most of his life. However, following his retirement, which was around 55 or 60, his life was littered by many events over the years up to the end of his life. And these were characterized by surgeries and hospitalizations, if you can see in that line graph above. This life of my grandfather inspired me to continue to study how to keep muscles healthy as we age. So next slide. This next slide is a simplified schematic illustrating the loss of muscle in the recovery period following a disuse event. I have here also, you can see, is an arbitrary red dotted line signifying the amount of muscle loss that results in disability. Next. My research goal is to intervene by preventing or reduce muscle deconditioning, thus improving the overall recovery period. We're also doing other research unrelated and not, I'm not going to show you some data on this. We're also interested in intervening during the recovery period when catching someone during the disuse period is not possible. Next slide. Despite this huge clinical interest in preventing muscle deconditioning and enhancing muscle recovery, sadly, there are currently no FDA-approved therapies, and yet there still remains a widespread interest in identifying novel therapies to correct this problem. Next. In fact, skeletal muscle has been coined the last undrugged organ. Next slide. We have even attempted to protect muscle deconditioning during a period of muscle disuse. In this study, we applied a common rehabilitation tool of neuromuscular electrical stimulation and combined it with a high protein supplement, which was enriched in the amino acid leucine. And the purpose of this was to reduce the loss of muscle and strength that's common with a disuse period. Next. So after 5 days of disuse while applying our treatment, as you can see on the bar graph on the left and the right, we were able to maintain muscle size in the treatment group, but unfortunately it wasn't good enough to prevent muscle weakness. Both groups you can see still got pretty weak. Next slide. Recently, we have been interested in repurposing existing drugs such as metformin. Metformin is a first-line therapy treatment to manage blood glucose in those with type 2 diabetes. Metformin is a multifaceted drug with many health effects that potentially could offset diseases and conditions outside of just glucose control and diseases associated with aging. In fact, several studies have been coming out supporting that those who take metformin have a lower risk of heart disease, cancer, dementia, and even more recently, osteoporosis. Next. Repurposing existing drugs is a lot faster and cost-saving than to make new ones, as you can see from the table down below. Next slide. There's also some evidence that metformin may improve muscle outcomes. Next. For example, those who take metformin lose less muscle with aging compared to those with diabetes who are not taking metformin. Next. Metformin also protects from muscle atrophy during immobilization and obesity related to muscle loss. Next. Finally, not only did metformin protect muscle from burn injury, but also protecting an important cell population within muscle called a satellite cell, which is also known as a stem cell. Next slide. The stem cells of muscle are called satellite cells because these cells are located on the border of muscle fibers. When a muscle is injured or needing repair or maintenance, satellite cells go to work and restore muscle structure and function. As you can see through this schematic, a life cycle of a satellite cell from rest to injury and then back to recovery. Next slide. An interesting observation in one of our bed rest studies in healthy older adults was that the satellite cell population of muscle tissue was greatly reduced, and in this case by more than 25%, as you can see on the line graph to the left. Next slide. So we did a short-term metformin study in healthy older adults who haven't taken metformin before and gave them metformin for 2 weeks. We collected some of these satellite cells from their muscle and tested how well they grow and function. Before the metformin treatment, you could see that the existing satellite cells don't grow as well as satellite cells from young muscle. On the left is a young, and on the right is an example of an older individual's satellite cells. Next. However, after 2 weeks of metformin treatment, the older adult satellite cells grew quite well and started to behave like young satellite cells. Next slide. So we came up with a simple question that metformin would improve satellite cell function during disuse, resulting in improved muscle function. Next. Some evidence suggests that there's even a better effect of metformin when combined with amino acid leucine. Plus, when combined with leucine, data suggests one might even be able to use lower doses of metformin to achieve the same benefit. Next, thus, we hypothesize that when metformin and leucine, the amino acid leucine, are combined and are provided during a period of muscle disuse, that muscle function would be preserved. Next slide. So we resorted to an animal model, circled down below, mimicking the deconditioning period that occurs with bed rest in people. Next slide. What we found after treatment with metformin and leucine in older mice was nearly a doubling of satellite cells during this 14-day disuse period, as you can see from black to the green bar. Next slide. Since satellite cells have been shown to be important in controlling the amount of connective tissue and fibrosis in muscle, and since muscle fibrosis is common with aging and injury and related to poor muscle function, we looked at the level of fibrosis in muscle. And as you can see from this bar graph, what we found was pretty striking. We found a significant reduction in the amount of fibrosis in muscle tissue when given the combination of metformin and leucine. And possibly these satellite cells may be related to the development or reduction of fibrotic cells. Next slide. Lastly, though we didn't see any protection against muscle atrophy, so the muscle still atrophied, what we did see was a dramatic rescue of muscle strength, thus improving overall quality of muscle. Next slide. So in summary, next. Aging is associated with poor muscle resilience, resulting in loss of muscle mass and function, also termed sarcopenia. And this possibly the development of sarcopenia could possibly be accelerated due to frequent disuse periods. Next. There are currently no therapies available to prevent muscle deconditioning to fully restore muscle function during recovery. And exercise rehabilitation is only partially beneficial, but certainly does not fully restore muscle function. Next. There may be an increased utility of using existing pharmacotherapies such as metformin, and in our data we show that metformin may target the satellite cells in muscle. Next. And when metformin is combined with the amino acid leucine, what you end up seeing is an increase in satellite cells, a decrease in muscle fibrosis, and an improvement in strength during muscle disuse. Next. I'd like to thank all the people in my lab that contributed significantly to these projects. These projects can't be completed without a team. Specifically, you can see I've circled here John Petrosilli, who's a PhD student in my lab. He's also on this YouTube video too as well. I obviously can't see him, but here's a picture of him circled there. He's a PhD student in my lab, and he conducted all these metformin and leucine experiments in mice. Lastly, as I said, it's a team effort. So thanks go out to all the collaborators within the College of Health and Health Sciences and the wonderful resources provided by the Clinical Research Center here on campus. Thank you very much for this opportunity.
Good evening, everyone. I'm happy to be with you this evening and talk to you about the use of robotic pets with older adults. Next slide. So a little bit about my connection with recreation. Recreation has been such an important part of my life. It's been a way that I have learned new skills and developed friendships, and many of the recreational pursuits that I enjoy have brought tremendous meaning to my life. Next slide. As I started my work as a recreational therapist, I've worked with people of diverse ages and different health conditions, but I've particularly enjoyed my work with older adults and have really enjoyed introducing them to perhaps some new leisure pursuits that they've not been engaged in before, and to see that the impact that that can have on their quality of life. Next slide. So recreational therapy is a systematic process that uses a variety of different recreational interventions to produce different health outcomes. And recreational therapists typically look at health holistically and are often focusing on different aspects of people's health and wellness. Next slide. My research focus, as Dean Perrin indicated, is that I look at technology-based recreation interventions and specifically how they can be used for rehabilitation and health promotion. This has a couple of different areas of focus. One, oftentimes when new technologies come out, I'm involved in evaluating the usability of these for people with disabilities and also for therapists, how they could take these technologies and incorporate them into their treatment sessions. This often involves developing specific intervention protocols, which can help the therapist know how to provide evidence-based therapies for the individuals they're working with. And so my research is often looking at evaluating the effectiveness of these protocols in producing different health outcomes. This also often leads to training therapists on how to use the protocols. So I'm going to be talking about my work with robotic pets this evening, but I've also done technology studies with virtual reality, technology-based music making, and video journaling, as well as some other technology interventions. Next slide. My lab at the University of Utah is called RT Squared. RT stands for recreational therapy, and it also stands for research and training. The logo was designed intentionally, and the four sides of the square represent the four stakeholders that I like to bring together on projects. The first being faculty and researchers like myself, the second being students, the third, clinicians or community partners, recreation therapists often, and the fourth being the clients that we serve. And the research that I'm going to be talking about tonight is an example of that type of partnership and collaboration. Next slide. So why robotic pets? Well, there's actually quite a bit of research about the health benefits of interacting with animals and pets in particular. The human-animal bond is very strong. However, when we particularly look at older adults living in long-term care facilities, so assisted living facilities, skilled nursing facilities, introducing live animals into those facilities can often be challenging. Live animals are unpredictable, and so you have to worry about things like scratches and bites and infection. And also, they don't always behave how you want them to, and so providing a structured intervention is often difficult. So with advances in technology, it's really exciting that we can now look to robotic pets to perhaps mirror some of those interactions. Next slide. Some of the initial studies on robotic pets has been very encouraging. There have been studies that have documented positive improvements related to depression, loneliness, pleasure and interest, positive and negative behaviors, communication and interaction of older adults, as well as activity participation. And the pictures on this slide show some of the robotic pet models that were first used in research. Next slide. However, there are a number of limitations in the initial research that was conducted. First of all, I mentioned my passion for creating protocols. A lot of the research to date is lacking specific protocols, so it's very unclear what the role of the therapist or the facilitator is and how they use the pet to produce the outcomes that they want. There's been a wide variety in the length of sessions, anywhere from 5 minutes to 30 minutes. People have not really been given a choice of pet. They've just been given the robotic pet that's been chosen for the study. And interestingly, people haven't really looked at what the participants' past experience with pet ownership might have been. The selected pets in past research also are not practical for widespread adoption. So these are some of the pets that have been used. You can see they range from pets looking very robotic, like the dog down on the bottom, who is Abo, to sort of stuffed animal looking pets, to highly robotic, soft and plushy, like the seal, which is Pero in the center. However, many of these robotic pets cost several $1,000s for one unit. So when I say they're not practical for widespread adoption, most facilities don't have a budget that would even enable them to purchase one of these pets. Next slide. So because of this, I was really excited when I saw the Hasbro company came out a couple of years ago with the Joy for All companion pets that are pictured here. There's a dog and a cat model. I actually have my pets here with me this evening. So this is Charlie, our robotic dog. And he's new to this whole, YouTube and Zooming, but he's greeting you. He's giving you a little bark here. This is our dog. And we also have a cat, which my students have named Oliver. And so Oliver is also here to give you a little wink and a meow to greet you this evening. So as people interact with these, they will also purr, they'll make other noises, and they'll move around. But for the study I'm going to be talking about this evening, we partnered with the staff and the residents at the Ridge Foothill, which is up the street from the U, and worked specifically with residents on the memory support unit. All of the participants were over 65 years of age and were able to engage in conversation in some capacity and had expressed an interest in pets and animals. Next slide. So the study that I'm going to be talking to you about, we offered these residents 2 separate robotic pet sessions for 30 minutes allocated for each. The sessions were scheduled 2 to 10 days apart and provided in the individual's private room. We gave the participant a choice of whether or not they wanted to interact with the dog or the cat. And then the student researcher who worked with me on this project, Becca Westenskow, guided them through a structured protocol. And we videotaped the session so that we could record how they were responding and reacting to the pets. Next slide. In terms of what we were most interested in gathering data on is, first of all, whether or not people enjoyed interacting with these pets. As a recreation therapist, we want people to have fun and enjoy it. So that's always something that I'm interested in finding out. First of all, do people enjoy this? We wanted to get a better sense of the ideal length for sessions, and we were curious whether or not people's past experience would impact how they interacted with robotic pets if they were familiar with live pets. We wanted to see what the most common interactive behaviors were and what questions the facilitator could ask to generate the greatest response. We also wanted to look at what techniques the facilitator or the therapist could use to promote engagement in interacting with the pet. And we were curious what impact the person's level of cognitive functioning might have on their interaction. Next slide. So real quickly, these are just some examples from the protocol that we developed, that we pilot tested in the facility and then used in our research study. These were some basic personal questions asking about people's background with their own pets. Next slide. We then moved into more directional tasks, cueing or prompting the person. Do you think the dog would like to be scratched on his head or behind his ears or on his belly? Would you like to brush the cat? And here we were noting if the question was asked or not and how perhaps the person responded. Next slide. We then moved into some more sensory focused questions. How does the animal feel? When it purrs, it vibrates. See if people would comment on that or how the texture of it felt to them. Next slide. These were more cognitive stimulation type questions, asking whether or not people could identify different types of cat or dog food, if they had memories of taking their animal to the vet, if their previous animals had favorite toys. Next slide. And then we had some cat and dog specific questions, recognizing that depending on the animal that the person chose, there might be specific questions that would be more appropriate. Next slide. So in terms of some of our initial findings, first of all, as I mentioned, we were very curious to find out whether or not older adults actually enjoyed interacting with these pets. And so at the end of each session, we asked them on a scale of 1 to 10, how much did you enjoy interacting with this pet today? And our findings were that people enjoyed it quite a bit. So our average score was 7.8 on a scale of 1 to 10, with people responding anywhere from 5 to 10 in their responses. Next slide. Because there's little research in this area, we were also curious about what it was about the experience that people enjoyed. So we asked these residents with cognitive decline, what did you like most? And these were some of the quotes that people shared with us. It was really nice to have that. I like to see him and act like he's having fun. He did what I wanted him to do and he didn't run off. So that's one advantage of robotic pets. They follow directions a lot better. They're funny and I enjoyed holding him. These pets actually have an option to mute them. So you did hear the noises that they make, and the ability to stop it was actually a woman who wanted to engage in conversation with the facilitator. And she said, can we make him stop? And the facilitator actually turned the barking off on the dog and she enjoyed that. I was able to approach the animal and I wasn't nervous. One participant particularly liked the dog's black nose. And we had one gentleman who really was very connected to the dog and just looked at him and said, I like that dog and he likes me. Next slide. We did ask folks if there was anything that they didn't like about the session. Most of them couldn't think of anything or didn't really have anything that they wanted to share about not liking in the session. We did have one woman who indicated that she liked the robotic pet, but she did prefer interacting with live animals and wanted us very specifically to know that she's quite fond of chipmunks. So since there is not currently a robotic chipmunk on the market, I'm thinking that maybe that's something that we can suggest to the company. Next slide. I mentioned that we were interested in getting a better sense of what's an appropriate length for these sessions. In past research, investigators had used anything from 5 minutes to 30 minutes. And so we set the max time limit as 30 minutes and really wanted to gauge if people got tired or seemed to lose interest. The range of interactions that we found that people wanted to engage was 19 to 36 minutes. That's actually a little bit beyond the 30 minutes that we set. We had a couple instances where the session was interrupted with a staff person coming in to try to provide care or interject, and so we included a little extra time at the end, and then some people were just a little bit slower to close out the session. So that was really helpful for us in letting us know that longer sessions actually are very helpful. Next slide. So as I mentioned, we were interested whether or not people's past experience might impact how they interacted. I showed you a picture of a robotic seal, and one of the explanations that the company had provided on why they developed a seal was that they were concerned that people who had had dogs and cats wouldn't respond well to a robotic dog or cat, and that people who had never interacted with a seal wouldn't have any preconceived notions. We actually found in the participants that we worked with that they actually did like interacting with pets that they had had, the type of pet that they had had, and some were interested in both the dog and the cat. We thought that people might, in interacting with the robotic animal, be more interested in talking about their live pet. And they were able to reminisce, but we actually found that some individuals really wanted to talk about the animal that they were holding. Next slide. In terms of the most common interactions, we saw people petting, rubbing, or scratching the robotic pets, communicating with them using pet talk. And by that, I mean talking to them in a way that we often talk to our pets. So that included both comments as well as voice and inflection. So we heard a lot of, oh, aren't you a good boy? Oh, are you talking to me? So that change in tone and inflection, and also the type of comments that they would make. Also very engaging facial expressions. Which often involved mirroring or imitating the sounds or the motions that the animal was making. And a lot of positive response to brushing or grooming the robotic pets. Next slide. In terms of the questions that people responded to the most, questions about their own pets and the names of those animals, people seemed to want to name the animals that they were holding. So we asked, what do you think this dog or cat should be called? And on the spot, people would come up with unique names like Hilarious or Bow Wow for the dog. And one gentleman who was able to say, well, I had a dog named Charlie, I'd like to call the dog Charlie. And then responding to these specific questions in terms of some of the sounds and motions that the animals were making. Next slide. In terms of the techniques that the facilitator used that promoted the highest level of engagement for the people in the study were taking the pet out of a carrier. So we actually brought them in a animal carrier, and we would see people leaning forward in their chair immediately and reaching to grab and pull the cat or dog out of the carrier. The facilitator often would have the other animal on their lap, and if the facilitator would start to pet the cat, then we would often see the participant start to pet the dog. Sometimes just repositioning the dog, should we see if the dog wants to lay down or roll over, would then re-engage the person to interact with it again, or asking a question. Some of those suggested interactions, like, do you think we should scratch it behind its ears, would then lead to that type of actual engagement with the animal. We did find that it was helpful to allow the individual to self-direct the session a little bit, to not make it so prescriptive in terms of the facilitator saying, now you'll do this and now you do this, or would you like to do this? Because we found that people wanted to interact in their own way. And particularly, we had one gentleman who really was having this almost spiritual connection with the dog in looking in its eyes, and the facilitator said it felt really inappropriate to even try to interject any kind of conversation at that point. Next slide. So we were interested in whether or not cognitive functioning level would impact how people would react. Yes, but we also found that there were other functional skills that needed to be considered. We had at least one individual who had had a stroke and had some aphasia, and so the ability to respond to questions was more a challenge of language than it was cognition. Those with higher level of communication skills were the ones who really were engaging more verbally. And we had at least one participant who was quite hard of hearing, and so the questions from the facilitator actually were sort of interrupting the interaction and the behaviors with the dog because he was struggling to hear the questions. Next slide. So some of our other takeaway information that we've gathered from our research so far. First, pet carriers are really helpful. As sort of a funny story, when we were first taking the pets into a facility to try out and develop the protocol, we took them in the boxes that they came in, and the student that was working with me came back and said, they all think I'm a salesperson trying to sell them a pet. So as soon as we took them in a carrier, people responded totally different, as if it was an actual pet. But they do shed just like live animals, so we take lint rollers as well. The ability to turn the sound off is nice. We found that the cat seemed to calm people more, where the dog tended to arouse people more. The choice was a really nice option, and it worked well to hold these in the person's individual room. I get a lot of questions of whether or not people know that it's a robot, and all of the participants in our study did. That didn't seem to be a barrier to interacting. And one of our first participants in the study was actually a retired veterinarian who enjoyed interacting with the robotic pets as well. We also found that the interaction with the pets helped people in generating conversation with the facilitator. So while the facilitator was asking questions, the participants would also then turn to her and say, do you have pets? Do you like cats? And that can be a challenge sometimes for people with dementia or cognitive decline. Next slide. So in terms of where we hope to go next, this has been very helpful for us in really refining the protocol, determining how we might be able to design this structured protocol that therapists or healthcare providers could use. We'd like to trial it with people of differing cognitive levels and in different settings, vary the number of sessions and the frequency that they're offered, and try to identify what specific outcome measures we might be able to collect additional data on. We'd like to refine the prompts, look at how these might be able to be used in group settings, and then identify what training staff at the facilities might need so that they could then use these in their day-to-day interactions in improving the quality of life of older adults. Next slide. Thank you so much. I've enjoyed sharing my research with you this evening.
Hi, everybody. Thank you for the opportunity to come out and talk with you tonight. I appreciate that everybody's here to listen to this great research that's happening at the College of Health. My name's Skylar Jennings. I'm a clinician scientist. I'm trained as an audiologist and also in research. And today I'm going to talk with you about, although modern hearing aids are great, why it is that they fail in noisy backgrounds. Next. So this is a picture of me during my undergraduate years, which was at the University of Utah. I had somewhat of an existential crisis when I was trying to figure out what profession I wanted to pursue. Next. So during one summer, 2001, I took a course called Career Life Planning, where we take a bunch of tests that sort of tell you what kind of profession your personality might fit best with. Next. So my test essentially had audiology at the top, which is what I am today. But there were many other choices, including this number 2 choice, which was to join the clergy. So as a very confused undergraduate, I, of course, went into physical therapy. Next. And so during my my days in physical therapy, I shadowed one of the physical therapists. Next. And this was at an inpatient hospital. And what I found, I had sort of a bad experience because many of the patients did not want to see the physical therapist. They didn't want to do their exercises. So I was under the impression that the physical therapist was somebody that patients didn't really like very much. Of course, I'm much wiser nowadays and know that there are various different areas in which a physical therapist can work, but I had this poor experience. Next. And again. And so what I did is I ended up shadowing an audiologist, and it was one of the audiologists at the University of Utah, Robert Wollenweber. And so this picture that you see here under the title audiology is actually a picture of the clinic, the hearing clinic, during the days in which I was a student, an undergraduate student. And this clinic was up on the 12th floor of the Behavioral Sciences building. And anyway, so I was able to observe one of these audiology interactions. Next. And what I was fascinated about was something called bone conduction. And so one of the things that an audiologist can do is they can place a bone oscillator just behind the ear. And this bone oscillator, what it does is it directly stimulates the inner ear. And so you can actually bypass the outer ear and the middle ear and get an assessment of the hearing of the patient from the perspective of their inner ear. So if there's any problems with the outer ear or the middle ear, we can sort of get past that with bone conduction testing. And I thought this was a very clever way from a diagnostic perspective to sort of solve a problem. You know, where is the problem occurring? Next. And during my undergraduate years, I also took a class from my now department chair, Dr. Blomgren, Michael Blomgren. And you can see there that I did very well in his class. And it's sort of an interesting coincidence that the picture of the lab that you see under audiology actually is my lab today. So where I observed as a student so many years ago, I now conduct research in that lab today. Next. After my undergraduate days at the University of Utah, I went to Purdue University, where I pursued a degree in as a clinician and also as a Ph.D. And after 2011, when I graduated with my Ph.D., I took up a position here at the University of Utah. And my plan is to be here as long as they'll keep me here. Next. So what I want to talk with you today is this sort of scenario where you're listening in a noisy background. So these individuals at this very busy restaurant are probably having a hard time hearing, maybe their conversational partner or something else that they might want to listen to. Next. And for older hearing individuals, older hearing impaired individuals, this is a particularly difficult circumstance, even with their hearing aids on. Next. And so you might put a pair of hearing aids on an individual. It might help them in a quiet background. You know, they hear their grandkids a little bit better when they're in a quiet background. But when they get into these noisy environments, they essentially want to take the hearing aids off and just sort of toss them into the drawer. Next. So what are the effects of hearing loss? Well, one of the first things is that hearing loss affects hearing, meaning that your hearing acuity suffers. There are certain sounds, certain pitches that you can't hear very well anymore. Next. The other effect that's not as well appreciated is hearing loss also comes along with something called tinnitus or ringing in the ears. So many individuals, a majority of them that acquire a hearing loss, also suffer from a constant ringing in the ears. Next. In addition to this ringing, individuals with a hearing loss may also suffer from something called low sound tolerance. So in other words, when they're in a noisy environment, they just can't tolerate the same level of sounds that they could tolerate when they didn't have their hearing loss, when they were younger. Next. Another thing that happens with hearing loss is that it influences your social life. Next. So for example, social isolation is very common. I've also often talked with patients who avoid these sort of social interactions because they feel like they just can't get along in them. They feel like people are going to ask them to repeat many times, and you know, their loved ones and people close to them might already know that they're not going to hear very well. And so they get frustrated and tend to isolate from those particular scenarios. Next. Another thing that affects a person's social life is the stigma associated with a hearing aid. And so patients often avoid getting a hearing aid, or they delay until they're a bit older because they fear the social stigma that's associated with the hearing aids. Of course, this stigma was really, I think, developed when hearing aids were much more large and clunky and quite ugly, to be honest. But nowadays the hearing aids are actually getting quite a bit better and more sophisticated looking. Next. Another important thing that hearing loss affects is achievement. Next. So for example, individuals that have a hearing loss, there's been studies that show that they're at risk for reduced wages in their job. They're not able to perform to the same level as individuals that have normal hearing in many circumstances, or at least on average. Also, there's stunted educational progress. So there's been a lot of studies in young students and how hearing loss influences them, especially after the 4th grade, when a lot of the requirement is to read to learn. So there's this stunted educational process that slows their achievement. Next. And then recently, we've discovered that hearing loss affects your risk for dementia. So individuals that acquire a hearing loss that don't treat their hearing loss, they're at greater risk for developing the symptoms of dementia. Next. The good thing is that treating your hearing loss can help. So one thing it can do is ensure that you have better hearing, you're more sensitive to sounds. It can mask the tinnitus that you hear. It can increase your earning power, increase your academic achievement, and slow the cognitive decline that comes along with aging. Next. There have been many improvements in hearing aids over the years. So this is sort of a quick and dirty overlook since 1946. They were very big and bulky back then. And we went through a period where hearing aids were all analog. They became digital. They got faster. They're able to do more processing. They got smaller. They didn't eat as much battery. And there's also been sort of these accessories that have come along, like a remote microphone, for example, where you can take a microphone and hand it to somebody that you are talking to, and they can wear it, and it will transmit their voice directly to your hearing. It's same thing with a cell phone. If you're talking on the phone, or if you want to listen to your TV, you can connect your hearing aid directly to your TV. Next. Okay, one of the big issues though is that hearing aids still do not do well in a noisy background. And this is the main problem that patients tend to express to their audiologists. Next. So they don't restore normal hearing. A hearing aid is able to sort of improve your ability to hear certain sounds, but there's a lot more that the ear does than just hear soft sounds. It processes very complex sounds. It adapts to sounds. Next. So what my lab studies is the ability of the normal ear to sort of focus when it's stimulated. So this is an example of a pixelated image that may be sort of a visual representation of something out of focus. All right, so what happens with the normal hearing ear is originally sounds might come into the ear and they look something like this, but the ear is able to focus over time as it's stimulated. Next. Next. And this is much like the accommodation reflex that your eye undergoes when you're trying to focus on an image that's either far away or close. So there's ligaments in the eye that can stretch the lens so that light is focused on the retina and you're able to sort of see the object of interest more clearly. Next. And so we have a similar neural mechanism that goes from the brain down to the end organ. You know, in this case, it's not the eye, but it's going to the ear. And the aspect of the ear that we're talking about is the inner ear, the cochlea. And inside the cochlea is where all of the information of sound is transduced or changed from acoustic and mechanical information to neural or electrical information that the brain can understand. Next. And so this connectivity from the brain to the cochlea, next, allows some control or some reflexive control and also attention-related control of the sounds that you're hearing. And one of the studies or one of the mechanisms that we study is called the olivocochlear reflex. And it reveals how the ear might focus to these, to images, to auditory images that you hear in the background or a noisy background. Next. And so here's an example again of a pixelated image. When this olivocochlear reflex is stimulated, what we think happens is the auditory system adapts in real time. Next. And this allows you to sort of focus on the image and hear better in a noisy background. Next. All right, so what do? We study this olivocochlear reflex, this ability of the ear to adapt to noisy backgrounds using perceptual studies, where listeners sort of, they listen to sounds and they make decisions about those sounds. Next. We also use non-invasive electrophysiological studies. And in our case, we were interested in what's happening at the level of the inner ear. So we've developed a custom electrode that goes down in the ear canal and actually touches the eardrum. Next. And this electrode is very delicate. We call it the baby hair electrode because it's very, very thin. And so our participants often don't feel it touch the eardrum. Yet we're able to measure potentials that come, electrical potentials that come from the inner ear, and therefore study the inner ear using a non-invasive approach. Next. What we found is our particular electrode is much, not only is it more comfortable for patients, but it's easier to be placed in the ear canal. So this image shows a commercially available electrode in A, and in B it shows our electrode. And what you might not notice from the picture in A is that the electrode itself is completely covering your viewing angle. You do not see the eardrum there, whereas in B you can clearly see the eardrum with our electrode on touching the eardrum. This allows the clinician to get a better reading. Next. The other thing we do is we study the olivocochlear reflex using a computational model of the auditory system. So we take our perceptual studies and our electrophysiological studies, and we relate them to the underlying physiology of the auditory system using this computational model. And this allows us to sort of interpret and explain our results in the context of mechanisms that are possible quantitatively as well as qualitatively in the auditory system. Next. So what are our goals? Next, first, our long-term goal is to understand and treat the difficulty that hearing loss imposes on comprehending speech in noisy backgrounds. Next. For the short term, we're interested primarily in this reflex, the olivocochlear reflex, and what is its role in helping us understand speech better in a noisy background. We also want to know if this reflex is abnormally weak in individuals that have a hearing loss. Next. And for our moderate term goals, we'd like to develop a hearing aid, develop and test a hearing aid or a cochlear implant or both that simulates the olivocochlear reflex. And we hope to do this in conjunction with our model simulations. The model simulations are quantitative, so they're easily transmitted into a device, right? All right, next. And next. So what have we found so far? We know that sounds are more audible in adults with normal hearing when the auditory system has time to adapt, when you stimulate this olivocochlear reflex. And we've shown that this is true for simple sounds, and it's also true for complex sounds like speech. Next. We also have shown that this focusing or adapting effect is not present in adults with hearing loss. So in other words, we can play the same sounds to individuals that have a hearing loss, and they don't tend to improve when you stimulate the system. They sort of stay at baseline performance. Next. All right, we've also shown that this lack of being able to sort of adapt to the acoustic environment is predicted with an auditory model. And that model has to have this reflex in it. So the model includes all of the physiology or much of the physiology of the auditory system. And if you don't simulate this particular reflex, we've shown that there's a lack of ability to adapt or calibrate to the local acoustic environment. Next. All right, we also have some preliminary work that shows that our non-invasive recordings with this eardrum electrode that I showed you earlier is sensitive to monitoring the neural activity in adults. And it's also sensitive to this adapting effect of the olivocochlear reflex. And one of the important aspects of this technique that we've developed is you can measure this reflex in an adult that has hearing loss. Much of the techniques right now that are available for studying the auditory system in terms of this reflex are not sensitive to adults that have a hearing loss. Their hearing loss prevents our metrics for being able to assess them. So this new technique is promising in that regard, that we'll be able to compare normal hearing and hearing impaired subjects. Next. All right, so for our future directions, we'd like to develop a quantitative framework for predicting how this reflex influences perception and physiology. Next, integrate this framework into hearing devices, and then test whether these physiologically inspired hearing devices restore hearing function in noisy backgrounds. I want to make a particular emphasis here. Hearing aids in the past, they've really been designed based on fancy engineering principles. And what the argument that we are making is really we need to make a hearing aid that is inspired by the physiology of the normal hearing auditory system. We know that normal hearing listeners do very well in a noisy background. Why don't we study why it is that they do so well? And once we discover what it is, let's embody that processing in a device and give it to somebody that has a hearing loss. Next. All right, so in summary, hearing loss affects a lot of things. It affects your hearing, it affects your social life, and it affects your achievement. Next. Hearing aids and cochlear implants help with a lot of things, and they've improved over the years, but they continue to fail to help individuals listen in noisy backgrounds. Next. A reflex, the olivocochlear reflex, we've shown helps individuals focus on acoustic images in noisy backgrounds and could help individuals with hearing loss. So the results from our lab show that if we were able to incorporate this sort of calibration of the acoustic environment into a hearing aid, it would help individuals that have a hearing loss. Next. All right, so we hope to build a device that's sort of inspired by this olivocochlear reflex. Next. I want to thank my lab and everybody who has contributed to the research and also our funding, which is from the National Institutes of Health and IDCD. It's been a privilege to be able to talk with you today about the research that we do. I hope you find it interesting, and I hope you come next time when there's another event like this. Thank you.
Hello, and thank you for the opportunity to tell you a little bit about myself and my research. My name is Alex Terrell, and I'm a rehabilitation psychologist. This just means I use my clinical skills to help people with chronic conditions and disabilities cope and adjust in order to promote well-being and quality of life. More specifically, my research focuses on not just the person who has the condition or disability, but their families as well. Next. For better or worse, families shape who we are, and that's no different for me. I was born and raised in Switzerland, but my family is scattered all over the world. My parents, brother, and I moved to Florida when I was a teenager, but it wasn't until I got a bit older that I became aware of the challenges of distance when my grandparents and more recently my parents started having health problems. The women pictured here with me all had strokes. My grandmothers both had multiple strokes before they passed, and my mom just had a stroke a couple of years ago. They were all affected really differently by their strokes, all had different kinds of support systems in place to help with rehabilitation and recovery. My grandmother, for example, was widowed and often lonely. She struggled with post-stroke depression, and her personality changed from being one of the kindest, most generous women I know into someone who, quite frankly, wasn't very pleasant to be around. But we all jumped in to help out, even those of us who lived far away, because she had always been there for us when we needed her. Next. This is my family's stroke story, but I'm willing to bet that many of you have your own story. That's because in the US alone, 800,000 people have a stroke each year. Statistically speaking, since I started this talk, 2 people in the United States had strokes. This makes stroke a leading cause of disability, and so there are millions of families around the world who are trying to figure out how to cope with and help their loved ones. To put this into local context, here at the University of Utah, hospital admissions for stroke are approximately 500 patients per year, with 3 times this number seen in our outpatient clinics. Notably, risk for stroke is much higher in rural areas, which is really relevant for us here in Utah. Next. My experiences inspired me throughout my schooling and have shaped the way I view stroke and other chronic conditions in the context of families. I received my Ph.D. in clinical psychology and specialized in rehabilitation during my clinical residency and postdoctoral fellowship at the University of Washington Medical Center in Harborview. Working in ICU, acute care, inpatient and outpatient rehab settings, one might expect to hear stories of traumas and loss. But instead, I was really struck by how remarkably resilient most patients were when they were faced with serious injury or illness. And it became clear that the patient's family was integral to recovery. They could either be their greatest source of strength or detriment. But family was often left out of the rehabilitation process, especially after discharging home, support was lacking. Inspired by my clinical experiences and fueled by the obvious need for more research in this area, I wanted a faculty position in a collaborative environment that would bring together my research interests, and I found it here at the University of Utah. One of the major draws for me was the university's reputation for stellar family and health research in the social sciences, as well as having a world-class academic medical center. The opportunities within the College of Health brought these interests together and opened up exciting possibilities for me for research and helping individuals and families cope with chronic conditions and disability. Next. So how can we better support patients and family care partners? Importantly, research shows that if a care partner is doing well, the patient has better outcomes. So for optimal outcomes, we should provide support for both the patient and the family caregivers or care partners. But existing interventions that have tried to do this are insufficient. They're either lacking or they're inaccessible. This is a gap that I wanted to bridge. And not surprisingly, given my family history, I wanted to focus on stroke first. I received NIH funding to develop and test an intervention for couples coping with stroke, which is the study that I'll focus on for this talk. Next. The intervention we developed is a strengths-based. This represents a reorientation, a build what's strong model that supplements the traditional fix what's wrong intervention approach of traditional medical and psychological interventions by integrating symptoms with strengths, risks with resources, weaknesses with values, and regrets with hopes in order to reflect the human experience in a more balanced way. We develop the intervention in such a way that it supports both the patient and partner, given what research has shown in the past. Next. So what did our couples do? At their in-person visit in the clinic, our couples received a 20-minute training on the intervention that we developed and how to do the activities. They could choose from a menu of activity options, which are shown here in the table. The activities consist of simple, short activities like expressing gratitude, fostering relationships, and working towards goals that couples could complete on their own at home. They were also given a booklet that contained all of the activities with descriptions and examples. There's a sample page here shown on this slide. They were asked to do 2 activities on their own and 2 together as a couple each week for 8 weeks. Let's look at a couple of examples of what these activities look like. Next. So the first one here is focusing on the positive. One of the activities included here was the 3 good things activity, in which an individual names or writes down 3 good things that happened to them that day. If this is completed as a couple, they would tell each other 3 good things that happened that day. The savoring activity was a particular favorite for many of our participants. Examples here include listening to music, enjoying a good meal, or looking through photographs and reminiscing about a happy moment. These could be done individually or as a couple. Our participants are given maximum flexibility to choose which activities they wanted to complete and in what order they preferred. Next. So what did our sample look like? To be eligible, our participant couples consisted of one partner who had a stroke at least 3 months ago and their partner or spouse. They had to be living together, and either one or both partners reported some changes in mood since the stroke. As you can see here, our couples were predominantly white, well-educated, which is reflective of this area that we live in. Notably, on average, our participants were 53 years old, although the range was 27 to 84. Nearly 40% of our sample was in their 40s or younger, so we actually had a really young stroke sample. A variety of stroke types and levels of disability were represented, including individuals with mild to moderate cognitive impairment and or aphasia, which is a difficulty with speech. This is a population that is typically systematically excluded from studies for various reasons, but we felt really strongly about demonstrating that our intervention could be implemented in a stroke population where some cognitive impairment and aphasia are really common. Next. So next. So the short story is that the intervention seems to work. When we were looking at some of our data on resilience, depression, and dyadic coping, which just means how well the couple coped with stressors, we saw some dramatic improvement in resilience for those who got the intervention as compared to those who did not. We also saw improvements in depressive symptoms and dyadic coping as compared to the group that did not receive the intervention. Next. When we looked a little bit deeper to see what was going on in our survivors and care partners separately, as you can see here, we saw some differences for the stroke survivors and the care partners. So here we see the survivors, where we saw significant increases in resilience, we saw depression decrease, and we saw dyadic coping improve. But really, these findings only held for the survivors and much less so for the care partners. We saw some changes, but they were not big enough to show up statistically. So we wanted to look a little bit closer and figure out what exactly was going on. Next. When we sat down to talk with our participants, that's when we really started learning about what our couples got out of this intervention. To illustrate this, I want to tell you about one of our couples. Let's call them George and Bonnie Jo. It's not their real names, and this is not their real pictures. George and Bonnie Jo are both 65 years old and had been together for 48 years. George had a stroke less than 1 year before the study and was having a hard time dealing with his perceived decrease and contributing to the family. While still willing to participate, George would remind the researchers during their weekly phone calls that he did not enjoy talking on the phone due to difficulties with his speech after his stroke. He was continuously encouraged by Bonnie Jo to keep trying, as she saw this as an opportunity to continue rehabilitation. Bonnie Jo was enthusiastic and eager to participate each week. She felt that participating would benefit her and George, and she played a crucial role in encouraging George to his full potential. Despite a busy home life schedule, they fully completed the study. When discussing his disability, George stated that after the stroke, I didn't do anything. That was my attitude. I can't do anything. His partner, Bonnie Jo, similarly reflected that he was in a negative mood since his stroke. George acknowledged that after his stroke, he was so focused on what he no longer did that he forgot to recognize all of the things that he was still doing on a daily basis. He wanted to feel like he was contributing to his family, but did not realize his contributions until he began to write things down he was doing as part of the intervention. He describes this aha moment. You go back to the notes for that week and go, oh, I guess I did do some stuff. It helped a lot to focus on what you do that's positive, and you communicate it. Why don't you rejoice in what you're doing, not beat yourself up for what you're not doing? The effects of these changes were not confined to George's personal life, but also extended to Bonnie Jo. While talking about taking time out of her day to express gratitude, Bonnie Jo commented, "I was feeling so overwhelmed with caretaking that I had forgotten that part of life." Next. Changes were seen not only on George and Bonnie Jo individually, but also their relationship. Both George and Bonnie Jo commented on how things changed for them when they incorporated activities that encouraged them to change their outlook in their daily life. Bonnie Jo stated, "When we were more positive with each other and with our activities and through the week, the whole week went better." George had a similar view. "I think she was more positive. I was more positive. That made a tremendous difference." When talking about their relationship and how they're coping with challenges, George noted, "My regular mode of dealing with problems is to withdraw." This only worsened after the stroke, as George was having difficulties with talking and expressing himself. As part of the intervention, they learned to shift from seeing this as a negative and instead learn to identify this as a cue that strengthened their connection. George commented, "I opened up more to her and she notices now that I withdraw. That's the first sign when we need to sit and talk about what I'm withdrawing about. And she's not critical. She listens and tries to help me work through letting go." Bonnie Jo noticed a change once she better understood how to approach George. When describing her communication with George, Bonnie Jo noted that, "I think he's more open to talk to me about problems and his feelings than what he was before." As a reminder, this is coming from a couple who have been together for nearly 50 years, who, because of a life-altering medical event, had to rediscover what worked for them as a couple. Next. These same themes of personal growth, communication, and relationship changes were seen in other couples. Many participants reflected on personal growth, stroke survivors who focused on their recovery and how far they've come rather than what they had lost, and care partners who felt empowered by taking a moment for themselves and changing their perspective. Next. Some of the most notable changes described by participants were in the relationship, and more specifically, redefining the relationship in the context of stroke. As one of our care partners said, "It helped me realize I could enjoy spending time with my spouse, not just someone I take care of. Feels more like what couples would do as opposed to just feeling like I'm a caretaker, which is something that I've struggled with." And a stroke survivor who said, "He was more empathetic. So the study had some real value, us thinking about it as a couple, not just me in my bubble of strokedom, but as a couple." Next. So to sum up the result, the intervention was well received, seemed to be resilience promoting for stroke survivors, with both stroke survivors and their partners reporting benefits beyond quantitative measures. Many of these revolved around shifting their relationship from patient-caregiver to relearning who they were as individuals and as a couple. We repeatedly heard from participants that the intervention provided a structure around which they could share activities and talk to each other about things other than the next doctor's appointment. So moving things from being stroke and symptom focused to enjoying each other's company and rediscovering and redefining a loving partnership versus a patient-caregiver role. As one of our participants with aphasia said when asked about the beneficial effect on the relationship, "Me, my partner, team." Hearing this from so many of our participants, I knew we were onto something. Next. Next. So these results were pretty exciting to us, and this research is still ongoing. We'll be making some adjustments based on the participant feedback and plan to test it in a larger national sample. The next step for me also included figuring out how to get this intervention out to more people who need it. With funding from the Craig H. Nielsen Foundation, we were able to develop an online platform for the intervention to help couples coping with spinal cord injury. Together with the Gaming and App Lab here at the U, I've been working closely with patient and clinician stakeholders to make sure the technology is relevant to the end user and accessible even for someone with a cervical level injury who uses eye gaze technology. For the online app, we've included a journaling function to track activities that can be shared by partners, as well as videos of activities that are pictured here. Our actors were real couples coping with spinal cord injury, and our filmmaker also had a spinal cord injury. I'm a firm believer in that in order to successfully implement interventions, it's important to involve and listen to the people who are directly affected, whether it's the patient, the family member, or the clinician. One of the clear strengths of our intervention is that it doesn't just apply to stroke. This could be applied to a variety of populations, like couples coping with dementia, cancer, or multiple sclerosis, with some minor adjustments. Next. So bringing it back around to the beginning of my talk, up until the end, up until the time of her passing a couple of years ago, I would call my grandma every week. And thanks to technology, we were even able to see each other via video conference. And we'd talk, and mostly she'd tell me about her day and how much she'd like for me to visit. My grandma never really understood what I do, what a rehabilitation psychologist means. But in our talks, she would say, "Oh, you help people like me who have had a stroke and who are having a hard time." And I'd agree with her. That is exactly what our work hopes to do, to improve well-being, not only in stroke, but for individuals and their families who are coping with chronic conditions and disability by providing accessible interventions. Next. And so with that, I'd like to thank all of our participant couples and stakeholders whose input has been absolutely invaluable. I would also like to thank my collaborators who represent various disciplines across the University of Utah campus and beyond, and a wonderful group of research assistants, in particular Jackie Einerson, my PhD student, who has worked with me on these projects from the beginning and is now moving on to her own research supporting stroke caregivers. And finally, the University of Utah clinics who have supported us through recruitment, and of course our funders. And thank you all for being here tonight.
Thank you, colleagues, for a most insightful discussion of some of the health issues we may all face as we age and how research is supporting a healthy process to reduce and cope with these issues. To our audience, I hope you feel empowered to speak with your loved ones and your healthcare providers about what you've learned tonight. We have a few minutes for questions. We've been receiving questions from the audience, and I will begin with Micah. Micah, we have a question generally about the influence of inflammation on muscle mass loss and gain with increasing age, such as, for example, the inflammation associated with increased osteoarthritis and other conditions. And does this mitigate the effects of hypertrophy training in older adults? Could you speak to us about the influence of inflammation?
Yeah, that's a real good question, Dean Perrin, and whoever brought that question up. Inflammation can hamper muscle growth with exercise training. It's been shown to be harmful to muscle tissue, especially the inflammations that's associated with osteoarthritis or other or age-related inflammation. Some people are under the impression that NSAIDs, such as anti-inflammatory agents, might impair muscle growth during like exercise, and it really depends on what population you're working with. Now, in younger individuals, taking inflammatory drugs to reduce inflammation may actually be harmful for the recovery of muscle. Inflammation is very, very important for the repair and structural integrity of muscle. And so when you completely shut that down, muscle can't repair. However, with aged individuals, if you were to take NSAIDs, there's two studies I know out there. One actually shows that it's actually not harmful during resistance exercise, and actually may be beneficial. And that might be because these NSAIDs could be lowering age-related inflammation. And there's another study where they immobilized older adults and they gave them NSAIDs with the thought that maybe the NSAIDs might help muscle recovery by reducing disuse-induced inflammation. They didn't see any further improvement in NSAIDs, but importantly, they didn't see anything worse with taking NSAIDs during immobilization and recovery. So that partly answers some of the question about inflammation. The good.
Yeah. Great. Thank you, Micah. Rhonda, we have a question about if a family member can purchase a robotic pet to assist with memory function and engagement for family members experiencing dementia, and also are there other methods to assist with memory?
Yeah, great. I'm glad that somebody asked that question. I mentioned that some of the early studies with robotic pets were using very, very expensive robotic pets. And I think I failed to mention that the reason that I'm so excited about these Joy for All companion pets that we've been using is that they cost about $100. So that's much more within a lot of people's budget in terms of, in fact, some people spend more than that on their live pets, I think. So, but it's much more financially feasible for people to purchase these. And there are people that are using them in private homes, not just in healthcare facilities. So I'm not connected to the company at all, but just a web search of Joy for All companion pets would give people information on how they could purchase their own pets if they were interested. And then in terms of the second question, or second part of that, I guess, is whether or not there's other ways to engage. Certainly, and obviously looking at what people's interests are is really critical. We were working with people who were interested in pets, and so then using a pet, but even just thinking about some type of physical tangible object or activity is a wonderful way to engage people and to generate discussion and also provide cognitive stimulation.
Great. Thank you, Rhonda. Skylar, we have several questions related to the impact of music in the background in the use of hearing aids. What is known about the influence of hearing aids on music, and what recommendations might we have for how to optimize that experience of enjoying music?
Yeah, hearing aids are very customizable today, and they can essentially, you can add a program, a listening program to your hearing aid that's specifically sort of fine-tuned for music. And so what that sort of program might do is give you a little bit more high frequencies. Those frequencies are associated with certain musical instruments that you may not hear as well because of your hearing loss. Those frequencies that it would be difficult to give you, say, in a noisy background, because it might cause the hearing aids to have some feedback or something like that. So an audiologist can make these sort of custom programs for you. If you go in and meet with an audiologist during an appointment, they'll plug in your hearing aids, and manufacturers of hearing aids have developed specific programs that they can load into your hearing aid that will make listening to music more, well, at least they're designed to make music listening a little bit more comfortable. Having said that, for individuals that have a cochlear implant, so that's a device for people that maybe have quite a bit less hearing, that they actually implant an electrode into the cochlea. You may have seen individuals with a device that has a magnet that sticks to the back of their head here. In that case, a cochlear implant really, there's not the sort of processing available currently to make music listening very comfortable. And it has to do with the way the implant processes sound. Some individuals can find, that over time it sounds a bit better, but overall music listening with the cochlear implant is currently, we're not able to provide an optimal experience for listeners.
Great, thank you, Skylar. Alex, could the positive approach of your findings be generalized to populations beyond stroke patients and their caregivers? That
is a great question. Yes, absolutely. There's actually a really large evidence base to support the effectiveness of these types of positive psychology-based interventions for a range of populations, anywhere from healthy older adults to individuals with type 2 diabetes, cancer, spinal cord injury, MS, and also in various modalities. So both kind of in person with a therapist, or on your own using online modalities or through workbooks and so on. Really, the novel thing that we're doing with this intervention, which isn't done as much, is that we are applying it to couples. So this idea that positive emotion, for example, can be contagious. And so the idea is that as you do these activities with a partner, you would both experience positive emotions that would interact. But absolutely, I would encourage anyone here who's, willing to try some of these activities to go out and try these very simple activities like expressing gratitude, practicing acts of kindness. They can be beneficial.
Great, thank you, Alex. Micah, I have a question that I'm going to modify it slightly. The question is muscle mass loss reversible at age 64? And since I'm 65, the question is it reversible at age 65?
You're 65 years old?
Yeah, can you believe it?
I got it. Yeah, so there's a lot of interesting data out there. First and foremost, to answer your question straight up, you can't fully reverse to one's youth again, if that's what you're asking. However, you are able to gain muscle mass following a resistance exercise training program. They've shown it in people that are in their 80s. And so exercise training could be useful to slow the loss in muscle as you age. And certainly you can gain muscle mass, but unfortunately we're not at that stage yet where you could gain the same size and strength as a young person. But it is possible to gain some, but just not up to a young person's level.
Okay, thank you, Micah. There's some hope left.
Yep.
Slow the deterioration. I have a question actually for each of you, if you're comfortable answering this, and I think it's an excellent question that all of us in the aging process think about. And what do you think is the most important thing we can do as we age to maintain independence? Would anyone like to take a stab at that?
Sure, I'll go first. Sorry, Alex, I beat you to it. Well, I would say the best thing that people can do is stay actively engaged in life. And as a recreation therapist, I certainly promote pursuing hobbies and leisure pursuits that give your life meaning, because oftentimes it's also those activities that you're physically active, you're socially interacting with friends and family, you're getting cognitive stimulation through the different activities that you're doing. And oftentimes those are ways that people also contribute to their spiritual wellness as well. So really focusing on promoting your health through staying active and doing the things that you enjoy will help you have a meaningful life and also maintain your health.
Great. Thanks, Rhonda. Alex, did you have a comment?
I'm going to go improv and say yes, and I would also add to that, in addition to engaging in the meaningful activities, make sure to take care of kind of the physical aspects, nutrition, sleep, exercise, kind of some of the things that have been mentioned during the talks this evening, as well as keeping mentally active, maybe try something new. We've all heard the thing about learning a new language or, something like that, but definitely keep yourself engaged, keep your mind engaged.
Great advice. Skylar or Micah, anything to add?
Sure. So recently, my mother-in-law has actually been really sick during the last 4 or 5 months. She's had a couple visits to the emergency room. And at one point, she was not able to care for herself. So we were helping out quite a bit. And she ended up going into a rehabilitation hospital and made a whole lot of gains when she was in that hospital. And now she's more independent. But one of the things that has really been a challenge is there's certain activities that she refuses to do. She does not like to talk on the phone with her doctor. She doesn't like to call the pharmacist. And I think part of it is because she has difficulty hearing on the phone. She also has difficulty with her sight. And so doing sort of, one of the things the doctor wanted her to do is enter some data into a spreadsheet, and so that they could track certain vital measurements that she was making every day. But I think she sort of neglected the treatments for her senses that allow her to keep her checkbook, that allow her to call her doctor, that allow her to track her medications and do all that stuff. And so one of my pieces of advice coming from somebody that studies the senses is do your best to treat those disabilities that are in your sensory organs so that you can continue to be independent and do those small things so that your daughter's not doing your checkbook and not doing your medications all the time.
Excellent. Thank you, Skylar. Mike, anything to add?
No, my solution, again, everyone has their angle on to the yes and. Mine is to stay as physically active as you can. You may not be able to play basketball or ski or what have you, but I mean, just going out in the garden and digging and getting those fruits and vegetables and enjoying the crop and going for walks. I mean, those are all ways you can stay active that are low exertion, and just keep that up as long as you can. But staying busy and staying active, I think has a lot of value.
Great, thanks. Well, thanks so much to my colleagues for a great job this evening and for all of your good work. We're out of time. This evening's seminar was recorded and will be available on YouTube. And please feel free to share that link with your friends. And please reach out if you have any other questions for our researchers. Evenings like this are only possible because of the generous support of donors like you. Thank you for your advocacy of University of Utah research and our faculty. And finally, on behalf of the College of Health and University of Utah Alumni Association, thank you for tuning in tonight. Healthy aging and good night.